to English, since this event, I believe, is also followed by a lot of people online. I have the pleasure to welcome first Stephanie Combe, our director of the Health Data Hub. You can sit here if you want. Yeah. I will also welcome Johanna Sebanen. She's the director of FinnData, the Finnish Authority for Health Data. Welcome, Johanna. I will welcome Fabrice Langlard, director of the DREES, Directorate for Research, Studies, Evaluation and Statistics. I will also welcome Damien Verger, Director of Strategy, Studies and Statistics at CNAM, the French National Health Insurance Fund. And finally, Joni Komalainen will also be taking part on this roundtable, Senior Ministerial Advisor at the Finnish Ministry of Social Affairs and Health. So welcome everyone to this roundtable, and we're really happy to have you here. So we said that we will try and get the lesson learned from the creation of all these national platforms. The aim of this roundtable will be to review and compare the implementation of both national health data platforms in two national contexts, in France and in Finland. To do so, we have invited the director of these platforms, but also the national stakeholders that made this possible. So we've heard a little bit about the Health Data Hub, or at least the context in which it was created in France. But now, Johanna, maybe as director of FinnData, you could tell us more about FinnData, first of all, and more specifically about the context in which it was created.
Thank you.
It's on. Yeah, it was on. No, I think you turned it off. So, yeah, okay. Yeah, it's on. Well, les aléas du direct. Is it on?
Hello.
Yes.
Okay. Thank you. Good afternoon and greetings from Finland. We just arrived yesterday, and thank you for inviting us to this nice event. It has been really informative and interesting so far, and I'm sure it will be until tomorrow. I'm from FinnData, as presented, and for those who are not familiar with FinnData, perhaps I should give a short description. FinnData is the one-stop shop for secondary use of social and health data in Finland. It is based on the Act on Secondary of Data that took effect in May 2019, and that Act is like a constitution for FinnData. It also gives us the mandate to issue or give permits to all data that is collected in the Finnish healthcare system. So all the data that is collected in the primary use or in the daily healthcare, where people are accessing the visiting doctors, accessing to hospitals, using social services, a lot of data is accumulated, and FinnData is then mandated to permit all that for secondary use. We put up the organization in very tight timetable. So I started in 2019, and we started to operate in 2020, stepwise, and now we are in full operation and having more or less 30 people in our organization, which I'm very, very proud of. Our main services or operations are, first of all, we issue the permits and we handle the applications. So if you want to apply for research health data in Finland from more than one data controller, you send the application to FinnData and we will then handle it. So in that sense, we act as a gatekeeper authority to the Finnish health data, secondary use of Finnish health data. Secondly, after the permit is issued, we collect the data from healthcare providers, from hospitals, from national registers, from electronic health records, wherever is needed. We collect the data to FinnData, and then we link it and combine it and provide it for you to be used in a secure IT system. And the third service is the IT system. So we provide a secure environment for applying data, for transferring data, for analyzing data and managing in all other ways. So that is our third service or task, if you want to put it that way. And for the fourth service, I would main service, I would name the help desk. So we have one single contact point in Finland, in FinnData, where you can ask help if you want to know about the availability, the quality, the coverage, the price, whatever you need to know. And that has indeed been very familiar, very famous, and very. It seems that it was a really necessary thing to put up. So we ask, we answer questions every day. I think 20 questions or 30 contacts per week or something like that. So it has been very popular. About the circumstances, FinnData was instituted before the Act on Secondary Use. If you wanted to have data for your search in Finland, for example, from 5 different data controllers, you should make 5 applications, so you would have to apply them separately. There were no standardized processes, that the processes were very time consuming, and also the prices were unpredictable. So that was, it was recognized that something has to be done, and that after the Act on Secondary Use was issued, then the one-stop shop was instituted. What has made it perhaps one of those cornerstones or circumstances that has made it possible in Finland is that we, first of all, we have a very long history in registers. So the longest registers, health registers, then back to 1950s. For example, we have all the cancers diagnosed in Finnish people registered since 1953 in the Finnish Cancer Registry. And they've been also used a lot. So using health data for secondary purposes is nothing new in Finland. It's just that we now have new rules and new act for that. Secondly, we also have the system or the situation called Opt-out system that that means that we don't need, in Finland, we don't need a consent to use your health data for secondary purposes. All the data that is collected in connection with the healthcare can be used for secondary purposes unless you opt out. So FinnData has provided a process for you to say, no, I don't want my data to be used for secondary purposes. But there are only very few people that have opted out. So practically all the Finns are in. So combined with the fact that the national registries have very good coverage, we have a really rich register and patient data sources in Finland. And well, the third and very important thing is the key that we have. So each Finnish people gets a unique number when he or she is born. So we have a identification number for each citizen that serves as a key when we link data from different registers. And well, it's one essential thing. And last but not least, I would mention the trust. It has been a lot of in our discussions here yesterday and today. In Finland, people in general trust authorities. They trust the data security and data safety authorities to keep them data safe. They also tend to trust that if their data is used, they will benefit back. So they will benefit as better medicine, better healthcare system, better facilities for social services. And they have seen it happening, so it's easy for them to trust. But it's not self-evident, and we are realizing that all the other authorities and trying to do our best to maintain that trust and to act worth it. Perhaps I think this was some first.
Yeah,
right?
thank you, Joanna.
Yeah.
From what you say, I feel like there's a lot of the challenges you face in Finland that we also face in France. And if I turn now to Stephanie, we heard a little bit about the creation of the health data hub in the introduction, and notably that it was interesting that the health data hub was created as part of the national strategy of the French president for artificial intelligence. And do you feel that since then the use of health data has been growing, and if so, does it imply any specific needs?
Yes, thank you, Ose. Indeed, the Health Data Hub was created during the development of this national strategy for artificial intelligence. And the idea at the time was to build data sharing platforms in various priority sectors, including health. Since health data are very sensitive, they cannot be processed outside the platform. So we need to build some platforms with the good requirements for artificial intelligence. So we decided with the Health Data Hub to design the IT platform to meet two challenges of AI, that is gathering big data sets of health data, and also providing big computing capacities for learning algorithms. And out of the 66 projects we support at the day, about 40% are using artificial intelligence. And I am pretty sure that this figure will continue to grow over the years, because AI is really useful in many fields of healthcare. And maybe I can list some examples, but it can be useful to improve screening patients thanks to softwares that automates and accelerates medical examination. For example, identifying tumors on mammograms. It can provide improve prevention. You can analyze data from medical device, for example. And one of the projects we support is matching data from pacemakers with hospitalization to predict health failure attacks. And maybe a last example, you can help practitioners while prescribing, because AI will make it possible to calculate the biggest risk of communications, for example, from a very large data set.
Maybe turning to you, Johanna, would you say that the use of health data has been growing in Finland too? And is it the same for artificial intelligence as well?
Well, sorry. As I mentioned, using data for secondary purposes is not new. It has taken place in Finland, and I'm sure in France also before. And we don't have comparable figures from time before FinnData and time after FinnData, so I don't have the facts whether there are more studies than before. But what I know is that now we are using more, the coverage of the data sets is bigger than before. So now, for example, we can get the same data from whole Finland or from the whole southern Finland via FinnData. It is also collected from places where it was very seldom done before. So, for example, county-based healthcare centers. Now FinnData is also getting data from there. So the data sets have become richer and wider in scope. What comes to the artificial intelligence, the classification is not so clear because people apply data for research, and we see the artificial intelligence as some kind of umbrella term. So there are studies that have an algorithm that is looking for something, or there is a study that has an algorithm that is really learning, or there can be a study with a huge regression model with 500 explanatory factors, and they are calling it artificial intelligence. So it really has to be looked case by case. But I would say that we have 5 to 10 applications for artificial intelligence per year. We are issuing about 300 permits per year. So I think it's less than with Health Data Hub, the specific artificial intelligence purpose.
I think what's clear is that in any case, whether it's artificial or intelligence or not, the number of projects and the use of health data has been growing both in Finland and in France. And now I'm turning to you, Damien, as a part of the National Health Insurance Fund in France, to meet this growing demand to access health data. Both FinnData and the Health Data Hub provide a technical platform to use the data, but that's not the only thing that's necessary. What would you say is the type of skills, expertise that are crucial to provide to guarantee that health data is used or reused in the right way?
Bonjour à tous. Peut-être, désolé, j'interviens en français. Peut-être pour commencer, repartir un peu du corpus juridique.
So to start, come back to the legal question, because we've got some rules in France which are not really restrictive rules, but they do guarantee that not just anybody can suddenly switch on to the data and use it for what, and that's important to know, because we're using personal data. We do have a same system as Finland with the unique identification per person, and so you can't, and it's coded, so you can't immediately identify them, and that helps us to link up, yes, with external databases, yes. And so in terms of the type of access, we've got permanent access for public institutions or institutions with public service tasks. They can use the database daily as they wish to, and that's what Dominic quoted. Outside, we've got 1,000 accounts, people outside the health system who can join up and access, who can connect and access. And all of this is within a framework, with a legal framework and regulation frameworks. And there are project accesses which are temporary accesses, and we have platforms which provide this access. And this is just a question of extracting the really well-defined study. And this, there is an ethic committee that looked at the project, which will look at the projects applying for the use of the data and whether it's a public interest or not. Check that they are respecting ethical rules and make sure that they have enough data to complete their project. It can seem to be a complicated procedure, but it provides the right structure to ensure that the quality of the project and also that they have the right data. And it's controlled by the CNIL, which is the National Right to Information and Freedom. committee also has a supervisory role. That's the first structural element, very highly structural element, in fact. And then we have this question of using the data. As Dominic said, we have databases which have been drawn up on price criteria, and these have been created to do medical-based analyses related to different pathologies. And this is a great source of strength because it will make sure that these are their exhaustive basis. As Dominic said, there's a universal protection for sickness care, which gives us a big universal amount of universal data. And if you want to be paid, then you need to put the right information systematically into the database. And it's also a weakness in some way, because we don't always describe very clearly, very properly medical information. Maybe we don't describe the different sectors of the population properly, and we need expert advice to use the right terms, the right categories. And we're very good at making very complex categories in France. And with the different categories to the different types of general practitioners is very complicated, and it requires very specific expertise and knowledge to understand the architecture of the databases, because it's not a big monolithic file, but there's lots of different tables which you need to know how to use, and you need the right software, you need to understand the categories, to understand the right variations, and you need to have a certain amount of medical expertise to look at the category and then know how to use it to identify a pathology. And this is very complicated software. And the CNAM, the National Sickness Fund, updates them and maps them every year. So it's very fine, refined use of the data.
So all of this work is very tricky, and we've got different researchers that are exploring this database, and people often underestimate the complexity of the database. There's a whole load of work to be doing to get used to the database. So the National Health Insurance body provides mandatory training for users. There's lots of online document, but there's nothing that replaces actually getting used to it by working with it. So if we don't open up this, the know-how of how to use this data, if we don't share the algorithms and the programs, then we will miss the opportunity that this data offers, this common good, this common asset. A final point to answer your question, there is the issue of new technologies and breakthroughs and advances that might be achieved through artificial intelligence. What we do know is that the computing power that is available now can give us a much more in-depth analysis of the data, and that will mean that we'll need new skills and talents. These talents are not that available, actually. We'll need people who understand technical architecture, who understand the new programming languages and make algorithms, people who understand the structure of data, data scientists, if you like. There aren't that, there are not that many people who do that. So once again, there is an issue here around pooling knowledge, sharing algorithms, drawing on different people's experience about what's worked, what hasn't worked. There's a whole load of work that needs to be done around the data and about the use of this data. there's some upstream work about the way data can be used. So there needs to be knowledge pooled about how to analyze it. And then there's a downstream part about how this data can be presented and disseminated, and how we can share what's worked, what hasn't worked. Thank you very much, Damien.
There's a lot to know and to have in terms of skills and expertise to even before analyzing the data. Johanna, would you say that you face similar challenges in Finland, supporting projects, or when it comes to training the right people and having the right expertise?
Yes, I totally agree, and it sounded very, very familiar, and I sign off all of that. It's also so that well, FinnData has now issued the data safety and security criteria or requirements that those environments have to fulfill where data is used for secondary purposes. So we are giving out the data to be used for secondary purposes only in environments that fulfill certain standards of data safety and security. And that is also that is new for everyone in Finland. It's also new for the IT developers and coders. So we are developing things and learning, and they are still like coming up. And I'm sure, and I'm really positive that a lot of solutions will also be in a quite rapid space upcoming. But well, it takes time. One field I would add that would need more resources and more support is the legal issues for researchers in university hospitals, in universities. We have very few lawyers working there to support researchers in these things, finding out what you can do and what you can't and where. And Joni, there sitting next to you, is doing his best in the ministry. FinnData has a lawyer, but that's not enough. So there should be lawyers in the field, research field, giving support and to the researchers to find out to sort everything out. So that's my addition.
Yeah, and it makes a lot of sense, and that's a nice bridge towards the governance aspect. If we turn now to Joni, that you've just mentioned, who's a ministerial advisor at the Ministry of Social Affairs and Health in Finland. Maybe, well, we've seen and we've heard maybe people here as well, that Finland has developed one of the pioneering texts in the EU, the Act on Secondary Use. Could you maybe tell us more about that act and the need to regulate data sharing or data access in Finland, and to which data does this allow access to?
Yeah, sure. Is it on?
I think it takes some yeah.
Some time.
Yeah.
No, it doesn't work.
Yes.
Anyway, yeah, what Johanna was saying, I totally agree with her. I could talk for hours about lessons learned from FinnData case and drafted the legislation, how to get it passed in the parliament. And it's not just getting passed in the parliament, it's the implementing phase of the legislation, which has turned out to be the most difficult part of the legislation process. Her advice to have lawyers involved in every stage is a welcome idea. And the problem in Finland has been that there hasn't been enough lawyers involved in actually understanding what the legislation says. The researchers don't necessarily always understand the Finnish legislation. So as there have been a few lawyers and they haven't always been familiar with legislation, okay, they have contacted me. So I'm the source of information in Finland regarding secondary legislation. If you go to the backgrounds of this legislation, as Johanna also mentioned many times, secondary use is not a new thing in Finland. Yeah, we have had had it for actually decades, and what she also mentioned, that we have high quality data banks that we have had for decades. That's sort of things you need to have, and we have the Kanta services for primary use. That's also one thing that we have had since 2007. So we have the healthcare data, and now we're starting to have the social affairs data in the Kanta services. That's one thing that's enabling the secondary use of those data. And what I have mentioned many times is that, yeah, we tend to talk about health data, but as the Commission has understood, it's not just health data, it's data related to health, as we see human being as a holistic human beings. So in Finland, from the start, we are understood it's not just health data that we need from the data banks, it's social affairs data, benefit data, and sort of socioeconomic registers that we in Finland have as well. Yeah, it has helped in Finland that we have the national ID code for linking those information together. That's one thing, lesson learned. Have something like that, if it's possible in your legislation field, in your country, that has helped a bit. The background of the legislation actually was, there were a few things. GDPR was coming, and the then current secondary use legislation wasn't in line with the GDPR. So we were in dire need of new legislation. Otherwise, we could have not used these data banks, the high quality data banks we have had for a long time. So it would have become impossible. So we needed to make it happen so we could use those data banks still in the future. That was one reason. Then the second reason was what was happening with, we had a constitutional law change. And the legislation we had back then were on a degree level, which is not a act level. So it needed to be on the act level in order to meet the criteria of the constitutional law legislation. So we had to do that. Those were two major things. And the third was the common reason that we understand. You could get the data from various data controllers with different processes, with different fees, and with different timetables. And sometimes it could take years, sometimes it could take 5 years to get the data, even from the one data controller. So there was a need for that sort of legislation to get it from one place with a certain strict process and strict deadlines and reasonable fees. Actually, in the past, it was possible to get it from the THL, which is the National Institute for Health and Welfare. You could get it from there, but even from there, it used to take a long time. And in one stage, it was possible to get it from the ministry. So Joni Komulainen was making all the decisions. So that didn't work either. What else I can tell about? Yeah, the lessons learned from getting this sort of legislation passed in a parliament, get everybody involved from day one. Hopefully, have everything public from day one as well. That's one lesson learned. And I mean, everybody involved, and even the stakeholders that don't agree with you still keep having conversations with those stakeholders. What we found out with the FinnData case was those stakeholders that were against the legislation from the start, that were supporting us in the parliament. Hannu Hämäläinen from Finnish Innovation Fund, Sitra, was actually doing lots of that work. He was still working for the ministry, having those negotiations with lots of different stakeholders over and over again. I don't know how he had the patience to do it, but he did it, and it helped a lot to get the legislation passed in the parliament, even in the stage when it was looking very difficult to get it passed in the parliament. Second lesson learned: keep having those conversations, the cooperation with all the stakeholders when the legislation is passed as well. Then you need to start doing the actual work, and keep having that cooperation still, and you have to have that cooperation going from the start and continue having a cooperation. Have cooperation with all the different data holders, data controllers, scientific groups, and of course you need to get the process better. The FinnData process needs to get better and better and better, but you need to have all of the different parties involved. The process doesn't work if you don't have the scientists who know how to make the data permit application. It doesn't work if you don't have the data controllers involved, because they have no interest in sharing the data. Okay, they want the money, but they're not interested in sharing the data. And the data permit authority's role is essential as well. So those are sort of things, lessons learned from Finland. What we did is, like I said, we had old legislation regarding secondary use. We managed to add some new use cases like development innovation activities, and then knowledge management, which was a new use case, and education and teaching activities. Those were the new cases. Sort of the other cases were sort of familiar cases use cases that you know, scientific research and statistics, and sort of development of sort of better utilization of decision making, while that sort of things, you know, helping the legislation better, and that sort of thing, steering the sorry, check the correct would be the personal, social, and health data for steering, supervision, research, statistics, development, and innovation. So that's sort of things we managed to enable in the legislation, and both involving the public and private sector. What was clear from day one was that we need to have the data processing happening in safe and secure environments. That we have managed to make happen. And we have actually, what we envisioned to happen was to have a chain of safe and secure environments throughout Finland with the same high quality of security demands, but different tools in different environments. And it's starting to happen in Finland now. We have 4 different environments, but there will be more. And that's a lesson learned for the Commission, for example, that one centralized system doesn't work. One centralized data permit authority probably doesn't work. But what doesn't really work is to have one secure environment. You need to have a chain of secure environments with different tools, different expertise. That's what you need. And one lesson learned from the FinnData case of Finnish legislation is as well that secondary use is not a one use case. There are many different use cases, and there are many different legislations regarding those use cases. So, like clinical medical trials is totally different legislation compared to the registers that the Finnish legislation is talking about. So you need to have a look at those different use cases and then decide whether sort of one fits all solution is viable or not. What else was I going to say? Forgot.
Well, I think that says a lot already. But please, if you have any more or any reaction.
Yeah, lessons learned from foundation of FinnData as well. What we did was we had timetables that were not really possibly realistic. They were sort of make it happen as quickly as possible. And we were pushing from the ministry, you know, make it happen quickly. And then some other people said, no, that's impossible. You can't do it, you know. And some people said, no, but make it faster. So we decided to put it in the middle. And what was amazing, they managed to make put those services up very quickly. Just imagine, we had legislation in 2019 May, and they had services in 2020 onwards. some of the services actually that they had to have implemented government legislation even in 2019. But the major services as of January 2020 and then April of 2020. The one thing that didn't happen in the timetable that we were planning to was the demand for safe and secure environments. That took longer, and we actually had to change that transitional period in the legislation with 1 year, and that was only 1 year, because it took longer than expected. Even though the idea of sort of safe and secure environments was in the legislation from the start, which, you know, it was in even in the early stages, we had the idea. And we even had the environments that we were sort of thinking, this is the safe and secure one. This is, you know, we would like to push for environment, for example, I think, you know, this is the environment, but they didn't meet the security requirements that we have put, well, actually FinnData put in the actual the degree in their specs. What we're actually now doing, because of the latter part of my random speech, is that yes, there are demands for the safe and secure environments that are sort of slightly Finnish inbuilt demands, but we have looked at the international standards, and we are trying to move the FinnData degree demands, the specs, more into international standards. So those standards could be easily adopted in Europe for all of us to utilize. And like, for example, for the European health data space regulation, we now have we have the specs now, and hopefully within reasonable time, we will also have the international specifications that could be utilized throughout Europe. Plus, we have those environments that could be sort of the lessons learned copied from Finland, or even bought those systems from Finland. Thank you.
Thank you very much, Jani. And we've heard a lot of things that were mentioned about the barriers, the obstacles, the governance, but also the short time frames into which we're trying to do all of that. And we've also heard about the role that the French National Insurance Fund has played in the access of health data in France. And now I'm turning to you, Damien, because we know also that in France, Fabrice, sorry, the Directorate for Research Studies and Evaluation and Statistics has also played an important role under the ministry as well. What would you say about, well, we've heard also about the other databases mentioned by Dominique. What are the obstacles and the need to regulate around these, the possible barriers?
Okay, thank you.
Thank you.
Well, as already was said by previous speakers, the issues surrounding health data are very strategic. And historically, the French situation was favorable thanks to our public health insurance system, which provided in sort of natural way the first database, the national database that Dominique spoke of. Namely constituted with medical administrative data, that is data registering care processes through the way we are publicly financing them and financing all the health suppliers. And so the last legislation, the 2019 law, provided an ambitious legislative and regulatory framework to go one step further, because now it conceptually, in sort of way, enlarged the perimeter of our SNDS, that is the French National Health Data System, to other medical databases, and by creating the Health Data Hub that is created to put in one single place all this, I would say, this intangible health patrimony, so that it can be shared and used for secondary purposes, and widely used for public and even private research. So the regulation framework is necessary indeed. And in fact, it's not even totally completed, because we we are in the process, I hope within days, to publish what we call the catalog decree, where we are setting the first list of new health databases integrating the SNDS. That is, expanded the scope. So we add to the historical, let's say, medical administrative data, first of all, COVID databases regarding vaccination and testing, that is medical database. And also we add a series of medical cohorts whom owners volunteered to share them into the hub. So that's a very important step. So is it sufficient once we have this catalog decree? Well, of course not. Because the issue of data sharing itself is struggling to be implemented, because research operators in France, and even public research operators who are owners of many registers and cohorts, but also public hospitals, for example, they are slow to enter this logic, and essentially for, I would say, institutional reasons. That is, in the current French system, efforts to build up health databases are only valued through research publications, for example, which leads the players not to share their data, or at least to slow a little bit this sharing, because they want to publish first on their data they build up. So this is why another step is to try to create the financial incentives to create, for example, hospital health data warehouses, on the condition that they will be adding these new data to the national health data system, and that they will be these new data will be shared with all stakeholders. And so my department and the Minister of Health is currently pushing ahead this project, and I'm confident, as Bruno said, that we have just launched a call for projects to constitute such a hospital data warehouses, and it will be financed with 50 million euros, which is a sum. We have also to support and securing health data collection projects in two fields that are still insufficiently covered in France. First of all, I would say medical activity of general medicine, that is the observation system for medical practices by physicians. And secondly, data related to measured or perceived health outcome indicators, patient-reported outcomes or experience measures. So you see that there is a lot of things to be done. And as was said, it rings a lot of bell to say that it is necessary to create the legislative and the regulatory framework, but a lot of work has to be done afterwards, not only technically, of course, but also to convince all the stakeholders and all the actors of the system to that the strategy that was put in place is the best one for the country. And so we have a strategic committee with all the stakeholders of the national health data system that is established and that is chaired by the Minister of Health to identify databases with the potential to positively impact research and innovation in health, and in the interest of population health, of course, but more generally to discuss with all the stakeholders all the issues related to the economic valorization and the readability, the governance around the data access. And of course, all this has to be done publicly, because we need citizenship transparency and trust from the public. Otherwise, it cannot be done. Thank you.
Thank you, Fabrice. So, well, a lot was said, and this was of interest to people attending remotely. So I have a few questions here, but we also can take questions from the room if anyone has any. Yes, do you have a question? Okay, so we would have people passing mics around in the room, and but maybe I'll start with a question from the chat, and then once you have a mic, I'll take a question. So the first question was in French, so I'll try to translate, but I think it's geared toward Finland. It says there's a unique identifier number attributed by birth in Finland. Does it allow to link different sectors, health, education, so different sectors beyond health?
Yes, yes. It's a key to everything that is in the Finnish registers.
So what type of other data this identifier is linked to?
So there is only one identifier for each Finnish person, and whatever data connected to that person you want to link, you can use that identifier as a key. So it works. It doesn't matter what field or sector. It works for all the data that is collected.
Thank you. And the follow-up question was, well, regarding the collect of health data, do they mostly come essentially from the public sector, or they can come from the private sector, such as private clinics or devices, connected devices or wearables and such like this? And I think this can also be a question for France, but please start, Johanna.
Yeah, FinnData has the mandate to issue permits both for public and private sector data. So if a researcher wants to, for example, combine some data from public and private sector, he or she can apply. Or if he wants to have data only from private sector, can also apply. So we will then collect it for you. So both sectors are covered.
And I think this was also a question in France. I don't know who wants to answer. La question était aussi en français. Est-ce que
It's a French question. Does the collection of French data, does it come from the public sector or from the private sector? Can it also come from the private sector?
Essentially come from public sector, because historically all the data we are speaking of come from the public insurance health scheme. But the idea to go further is to, in this new and enlarged system of health data system, we are planning to integrate other medical data that could come from the private sector, in particular data related to medical observations or medical practices.
Thank you. I think we had one or two questions from the room. Dominique, and then one here. Okay.
Thank you very much for your speech. It was very interesting. I had just a couple of questions. First, are all stakeholders allowed to use the data, whatever there are, industrials or public researchers? Can everybody use the data? Second, you're issuing permits to use the data. Do you have general criteria, or do you evaluate the demand with your? How do you do that? I mean, because we have for instance, a committee which sort of evaluates the methodological and ethical aspects. Do you do the same or not? And my third question, which is important, is that I understand you have this mandate to collect data from all sorts of databases, including private databases, and you were speaking about the price, if I don't mistake. So how do you, are these stakeholders who own, I don't know if the own is the right term, but the databases, are they obliged to share it, or is it a sort of legal obligation for them to do that, or are they incentivized with financial aspects? Is there, how do you get this general acceptance to share the data?
Okay, I will try my best. Perhaps if I start from the last question about the money, about the price. Yes, the healthcare providers, both on public and private sector, are obliged to provide the sample that FinnData is asking, but they are also they will get have a price for that, so they can themselves define how much they ask for the data sample, and we will then ask about the price, about the cost, and we will tell the client. And before we make we make the decision, we will then have the total price, and the applicant will have to approve it. And that's very time consuming. Otherwise, we would be quite quickly issuing the permits, but discussing and finding out about the price, because then they get to know the price and then they change their minds. Well, I'm not taking all of this. I'll just go for that and that. And then we will go back to the stakeholders and ask for the price again. And then you see the, yes. To your first question, everybody can apply. So I think something like 28–30% of our clients come from private sector, but most of the clients come from the public sector. From our perspective, the digital or the division to public and private sector applicants is a little bit old-fashioned, because we see consortiums. They may be led by the university. Pharmaceutical industry is joining in. Perhaps some third sector parties are joining in. So it's not always clear whether it's public or private. So I think this is it's a little bit. We could let the division to public and private a little bit behind us, I think. And what was your third? Yes, we don't have a scientific expertise or scientific assessment that is done elsewhere. So that universities and research institutions are giving the permit or green light to go further with the research. What we do, we looked at the purpose is right. So Joni was listening the purposes, research, statistics, development and innovations, teaching, and so on. We make sure that it's the data utilization plan or research plan is for the right purpose. We make sure that there is properly educated person leading the project, and we make sure that the data safety and the data security issues are taken care of. And after that, yes, you can have the permit. So, of course, we consider issues coming from GDPR, like the principle of minimization. So, if it's very vast or big amount of data, we start to start the dialogue. Well, could you restrict this a bit, and could you do with a little bit smaller sample or so? And after that, yes, you can have the permit.
Yes, please go.
First of all, to the question, who can send a data permit application? Anybody can send a data permit application. Even you from France can send the application to FinnData and can get the data from the remote. You can get remote access to the Capsuli environment, or if there are other environments that you would like to use that would fulfill your needs more precisely, like the environment from whose then that could be used as well. The qualifications, what you need to fulfill in order to get the data are stated in the legislation. So there are various different demands that you need to fulfill in order to get the data for various different purposes that I have gone through and Johanna just mentioned. And of course, you need to meet the needs of the general data protection legislation and many other different legislation. So it isn't as easy as it seems to be, but you don't need ethical committees or anything like that to get these sort of registers used for these purposes mentioned in the legislation. Thank you.
Yeah, that's a good point. So we have actually quite many researchers outside of Finland using Finnish databases in our environment. So you can access from all over the world once you have the right.
Well, that answers actually one of the questions in the chat asking whether you could access, French institution or private sector could access data in Finland. There's a few questions here. I'll try to get one or maybe one, and I think there was also one in the room, and then we'll have to wrap up for the break. There was one notably to you, Stephanie. As for AI application for secondary use of health data, who is responsible? Referring back to the example that was mentioned with regards to prescribing medicine, who is responsible if a mistake is made? That's not an easy question.
Does it work?
Yes, I think so.
The responsible of treatment is responsible for the research, and in the platform of the Health Data Hub, we just consider the research. But in the examples I gave, for example, the development of a software, obviously the software needs to be certified by another authority, which has nothing to do with the Health Data Hub. But for the research, the project leader needs to get the permits also. But in France, this is organized differently with a scientific and ethical committee first, and then the national authority that accept or not the research, and the Health Data Hub or the national insurance must give access to the data if the national authority authorized the project.
Thank you. I think we can take one more from the room here. And for the question that we would not have answered, I propose that we will send them to you, and we can maybe post something about with responses.
Thank you. Thank you for the presentation. It was very clear, very rich also to know about the Finnish organization. I have a question with regard to the nature of the data you're collecting today, and maybe if you have some plans for the future, what type of data. So do you have today, for instance, medical notes? Do you have MRI? Do you have genomic data in your database we can access? And maybe a few thoughts around moving forward, where you think you're going to be collecting in the future that you're not collecting today.
Thank you. The answer is that even we are a one-stop shop for the permits, so that's centralized in FinnData. The data is not centralized. We are, for each study, we are making a sample request to the organization stakeholder data controller, providing that data case by case. So we don't have a data pool where we are collecting data, but we can deliver you all the data that is collected in the whole Finnish system. So all the pictures and yes. If I've made it clear, yes.
Yes, please.
There was a question about was it biobanks or genomes as well. It's not a part of the legislation
That's
yet,
true.
because we actually have been very unfortunate with those legislation for various reasons. One reason was the Sipilä cabinet resigned, and we couldn't get those legislation passed because of that reason. But anyway, we'll have a new biobank legislation coming and genome center legislation coming. There are certain difficulties getting that sort of data within the scope of this sort of legislation that we have actually in Finland, but we're working on it. The third thing we don't actually have in this scope of this legislation is the data regarding clinical medical trials, because the EU legislation regarding those that sort of data is very complex. It's very difficult to meet the demands of the Secondary Use Act, the high security demands, to the other security demands that are in the clinical medical trial legislation, the EU legislation especially. So the two different worlds, so how to make them work together. So those three things that we're actually working on at the moment, and that's why I was mentioning, referring to the Commission, that it's not just one use case, there's several different use cases and different EU legislation in the background, which makes it very difficult to make it compatible in the national legislation. But we're working on it.
Yes, if I can comment, I was reading the proposal for EHDS, and I was surprised to read that they also want to cover the clinical research. So it would be very interesting to see how that is happening. Thank you.
Well, thank you very much. Unfortunately, we don't have much more time for questions, but thank you all of you for participating to this roundtable. We'll now go on a short break, 45 minutes. We're running a little bit late, so please keep an eye on your watch if you're watching remotely. And well, first we'll tell you when to come back. Thank you.